Welcome to the National Bone Marrow Transplant Link, managing oral health issues before, during, and after a bone marrow and stem cell transplant with a focus on GVHD call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Jennifer Gillette. Please go ahead.
Thank you, Hannah. Yes, my name is Jennifer Gillette, and I am the staff social worker at the National Bone Marrow Transplant Link. I'd like to welcome you to our Lunch and Learn with the Link. This month's program will focus on managing oral health issues before, during, and after a bone marrow transplant with a focus on GVHD. A special thank you to our sponsors, the Leukemia and Lymphoma Society, Jazz Pharmaceuticals, Insight Corporation, Pharmacyclics and Janssen, and our esteemed Link partners for making this program possible today. Just so everyone knows how our program is going to go, I'm going to give you a brief introduction to the outline and to as far as the services that we at the National Bone Marrow Transplant Link offer. And then I will hand it over to our medical speaker, Dr. Jacqueline Mays. And then we have a survivor joining us on the call today, Cathy Spence. And then we are going to have our question section. And we'll start with the doctor answering some of the previously submitted questions, and then we'll open it up for any questions those on the call have. And then we'll close with just a few minutes of resources at the end. So for those who may not be familiar with the link, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are webinars, podcasts, blogs, lunch and learns like the one you're on today. Some are disease-specific, some are topic-specific like caregiving or coping or treatment options or survivorship. We also have a wonderful peer support mentor program where we can connect patients, caregivers, and donors with those who have walked this journey before them. And we have a second birthdays recognition program. And we have plenty of books and referrals, and we provide emotional support from a licensed social worker. So if you need any services or extra support, please feel free to reach out. Before we begin today's program, I would like to review just a couple housekeeping items to maximize the experience of all on the call today. First, we ask that you please be mindful in being concise with any questions you have so that we may answer as many as possible. Also, please know that the information provided in this program is meant to stimulate conversation with you and your own healthcare provider and is not meant to replace your individualized medical plan. So now onto the educational part of our program. We're so thankful to have our first speaker with us here today, Dr. Jacqueline Mays. Dr. Jacqueline Mays is an immunologist and clinical trials dentist whose research is focused on chronic graft-versus-host disease in the salivary glands and oral mucosa. She is a NIH Lasker Clinical Research Scholar and heads the oral immunobiology unit within the Division of Intramural Research. Her laboratory's work includes the immune and physiological causes of salivary gland dysfunction following allogeneic stem cell transplant and the pathogenesis of oral CVH or chronic graft-versus-host disease with clinical trials directed towards advancing chronic graft-versus-host therapy. Previously, she completed a clinical research fellowship at the NIDCR and has a Master of Health Science degree in clinical research through Duke University College of Medicine. Prior to joining the NIDCR, she was a postdoctoral fellow in the Lab of Viral Diseases at the National Institute of Allergy and Infectious Diseases, the NIH. She completed her DDS and PhD degrees at the Ohio State University College of Dentistry, and she holds a BS in Biology and Chemistry from Valparaiso University. And I'm sure I mispronounced some things. I apologize there, Doctor, but welcome. Thank you so much for being here with us today.
Thank you so much, Jennifer, for that incredibly kind introduction. Some of those things are a mouthful. I grew up in Ohio, and I did my dental training there, and that Midwest sensibility has really stuck with me, and it's a big help when it comes to working with cancer patients, and especially with oral graft-versus-host disease, because above all, we have to be practical, forward-thinking, and at the end of the day, we really want to do something that is either going to make our patients feel better or improve their disease. On really good days, we get to do both. So I've had the privilege of working with transplant patients at the NIH Dental Clinic, which is in the Washington, D.C. area, for almost the past decade. Through that time, you all have taught me so much, not only about graft versus host disease, but especially about how resilient the human spirit is as you trek through the long, in some cases very long journey before I see you. Sometimes this is before transplant, and more often it's long after transplant through one of our chronic graft versus host disease research programs. I'm also acutely aware that we don't have great treatment options in many cases, and one of the privileges of being at the NIH is that I also run a research lab where we are focused on understanding how graft versus host disease works in the mouth, and especially on finding new treatments that can improve oral graft versus host disease. So I had the great privilege of meeting Peggy Burkhart and Jennifer Gillette a few years ago, and I'm incredibly impressed with the educational and grassroots work that is being done by the nbMT. It's a great privilege to be here today, and hats off to these very committed individuals for meeting this very unmet need. Today, we are going to walk through what to do before transplant, what you can expect early and later after transplant, and things that you can do to take care of your mouth. Everyone's experience is unique. Peggy was kind enough to share some of your pre-submitted questions. I've tried to incorporate this information in the material that I'm going to talk about today, and we'll answer some of those questions at the beginning of the Q&A. And, of course, you're welcome to ask questions at the end, particularly if I'm not clear or if you want more detail on a specific topic. Okay, the Cliff Notes. See your dentist regularly after your transplant has stabilized. It's easier to fix small problems than it is to fix big problems. This goes for both your teeth and with graft versus host disease in your mouth. Call your dentist if you notice any problem or change in your mouth. This includes things with your teeth, something that looks funny on your tongue, or something that's changing on your lips. Take care of your mouth by brushing and flossing every day. A healthy mouth is less likely to develop problems. I will point out here that graft versus host disease cannot be prevented by brushing and flossing, but other problems can be prevented with good oral hygiene. I was asked to talk a little bit about the oral to-dos prior to transplant, as some of you may be heading into a transplant and thinking sort of at the very beginning of this journey. See your dentist. Your transplant center has probably asked you or requires you to gain a pre-transplant dental clearance. Ideally, you'd be able to see your community dentist. If your cancer center does offer dental care or has a dental clinic, it would be a good time to establish a relationship with that clinic if you have the opportunity to. Before transplant, there's a lot going on, often with a very short time frame. Your dental clearance is still an important part of keeping you healthy through your transplant and also long after your transplant has engrafted. So what do we look for during a pre-transplant dental clearance? What's going to happen? It's going to feel like a pretty standard dental exam. So we'll take x-rays of your mouth to look for cavities, root infections, and any other hidden dental problems. Things like cracked teeth, roots that were left behind after teeth came out, any artificial dental crowns that are about to come off, or wisdom teeth that could trigger infections while you are immunosuppressed or immunocompromised. We check your gums. We clean your teeth, ideally if there's enough time and if you're medically stable enough when we see you prior to transplant. And then we'll talk about care for your mouth early after transplant. This can include, so early after transplant, when you're still admitted to the hospital, cleaning the teeth can include using soft swabs or little foam lollipops that are sort of on a little stick, using an antimicrobial rinse like chlorhexidine, or using an extra soft toothbrush along with your normal toothpaste. In a research setting, at this pre-transplant visit, we also measure your mouth opening and see how much saliva you can make in 5 minutes. These two baseline measures give us an idea of how your mouth was before your transplant, so that we can look carefully and know if your mouth opening or salivary gland function are changing after transplant, so that we can catch that early. Special care of the mouth that's needed as a cancer patient. check your toothpaste. Make sure that you're using toothpaste with fluoride in it. You may have a sensitive mouth. If this is the case, using fruit-flavored or children's toothpaste, again, children's toothpaste with fluoride in it can help. So there's some specific brands that make fruit or non-mint flavors. Burt's Bees is one of them, and Tom's of Maine also make sort of fruit-flavored toothpaste that can help if you're sensitive to mint. If you have sensitive teeth, using fluoride rinse or gel or desensitizing toothpaste, things like Sensodyne, Pronamel, Colgate Sensitive, et cetera. There's a whole array if you walk down the dental products aisle at your local store. There are also professional desensitizing treatments that your dentist can apply. There are things that can be painted onto the teeth and cured. There's something called gluma. If you have roots that are exposed where your gums have worn away, those areas can be very sensitive on your teeth. And sometimes a periodontal surgery called gum grafting is needed. And there are also some laser treatments that can be done to desensitize teeth. Just a little bit more about fluoride. Patients undergoing head and neck irradiation, which most of you probably have not, often have custom fluoride trays made that look like retainers. These just slide right over your teeth. They are filled with a thin line of fluoride gel 1 or 2 times daily and are used to intensively remineralize tooth enamel. We will sometimes use these post-transplant in patients who have dry mouth to help remineralize those teeth as well. So your teeth are made of hydroxyapatite crystals, which are composed of calcium, phosphorus, and oxygen. When you have an acidic environment in the mouth, either from bacteria metabolizing sugars, from foods that you eat, or from a lack of saliva that's no longer there to wash away those food particles and neutralize those acids in your mouth, this causes the calcium from the tooth structure to leach away. So this can be replaced so the calcium that's lost from your tooth crystals can be replaced by the slightly smaller fluoride molecule that can help reform those tooth enamel crystals and protect your teeth. So it can also help to insulate your teeth by blocking the spaces between the crystals. This helps to reduce tooth sensitivity to hot and cold, for example. Fluoride can get a bad rap, and I think it's important to explain exactly why it is so helpful to protect your teeth. It's not a government plot, but it can be quite helpful to help prevent decay and improve dental sensitivity. And then just another note, if you have limited joint mobility, which we often see in patients with sclerotic chronic graft-versus-host disease, it can help a lot to use an electric toothbrush. So any kind from the $6 spin brush that you can find at Walgreens to the much fancier models, basically anything that you're comfortable using can help to clean the teeth just a little bit better if you're having some wrist issues. So one of the things that we wanted to talk about today is how to find community dental care or a dentist who will work with you and help you with your sort of less standard issues. So tell your dentist that you're a transplant survivor. Don't wait till the end of the visit to mention, oh, by the way. Show your dentist anything unusual or new that you see or feel in your mouth. So as a general rule of thumb, mouth ulcers, lumps, and bumps should heal within 3 weeks. If something shows up in your mouth and it hasn't healed within 3 weeks, then it's time to either go see your dentist or let your transplant physician know at a follow-up visit that there's something in your mouth that needs to be looked at. And this goes also for your teeth, gum, lips, and cheeks. So do ask for an oral cancer screening when you're at the dentist. And make sure that they're actually doing that screening. They should be doing it every time you come in, so every time you're in for one of your 6-month checkups. Oral cancer has the highest risk in post-transplant patients with a history of oral chronic graft-versus-host disease. These things tend to show up around 5 to 10 years post-transplant, and the sides of the tongue are the most common site for these things to arise. So typically these are squamous cell carcinomas, and I don't want to send you into a panic. So the risk for oral cancer is quite low. Even that very low risk that increases in patients with a history of oral chronic graft-versus-host disease is still very, very low. But your dentist should be looking in your mouth every time you're in for a checkup to screen for oral cancer. So signs that you might need to see a dentist or an oral medicine specialist or a cancer center dentist, somebody who understands graft-versus-host disease, would be if you have new taste changes that weren't present right after your transplant. Obviously, chemotherapies, radiation, and transplant medications can all affect your sense of taste. But the normal course for this is that it improves either slowly or quickly after transplant. If you suddenly lose your sense of taste, and it's not because you have a cold, and it's not because you started a new medication, it may signal changes in the soft tissues of your mouth. If you develop new sensitivity to spicy foods, if you have new dry mouth, especially, again, if you haven't started any new medications. Sometimes the dry mouth can happen at the same time as dry eyes, but not always. If you notice whiteness on your lips, on your tongue, or on the linings of your cheeks, this can look like a white coating that doesn't wipe away, or it may look like lacy white tracings on the inside of your mouth. Not every dentist appreciates your complex medical history and needs. If your dentist is not a good fit, interview other dental offices. And you don't really have to, apologize for trying to get past the front desk and say that you want to talk to the doctor or you'd like to set up a time to talk with the doctor because you want to make sure that he or she is a good fit with your dental needs. Ask the dentist if they have experience treating medically complex patients, or ask the office if they treat many medically complex patients. Universities with a dental school faculty or resident practice are, as a general rule of thumb, excellent places to seek care, or medical center clinics, because these places typically have advanced training and are more knowledgeable about complex medical conditions. So dental care has changed a lot with COVID-19 and the current pandemic, and good dental offices are taking exceptional measures as they reopen to protect patients from aerosol transmission of the SARS-CoV-2 virus and other pathogens. Ask them how they're going to protect you, particularly as an immunosuppressed individual, if you do need to come in for dental treatment, especially in the next few months and through the summer. So thinking about how your mouth can change after transplant, those of you who have been through it know that in the first 100 days, so really early after transplant, you can develop mucositis, which is painful, but it's not graft-versus-host disease. And dry mouth, these things are mostly resultant from pre-transplant chemotherapy and radiation. Oral thrush can occur. This is overgrowth of yeast in your mouth that's quite common if you are deeply immunosuppressed. In sort of the interim period, both a little bit later after transplant, we can see drug-induced complications. These are oral side effects that result from using methotrexate, sirolimus. We can see reactivation of viruses. Things like herpes simplex virus or cytomegalovirus can reactivate when you're immunosuppressed, and those will cause ulcers inside your mouth. Generally, after 60 days, that's when we'll start seeing signs or symptoms of chronic graft-versus-host disease. We've seen this show up as early as, well, I personally have seen this show up as early as 60 days post-transplant and as late as 3 or 4 years post-transplant. Although we would like to think if you make it through the first 6 months, you're completely out of the woods for oral graft-versus-host disease. We know that there are specific cases where it can still occur. So symptoms of graft-versus-host disease in the oral cavity. Many of you listening on this call can describe these better than can I. Dry mouth, we know that your salivary glands specifically are a target of graft-versus-host disease. Lack of saliva production is really the only sign, and this can happen very slowly. So it's difficult to notice when it's occurring. You may notice red or white patches in your mouth that you cannot scrape away. Not that I'm recommending that you scrape the lining of your mouth, but just very gently, if they don't brush away, then you know it's not a food particle that's stuck in there. Mouth ulcers may occur, white lines on the lining of the cheeks or other mucosa, and the mucosa are those like wet, slippery tissues inside your mouth. So your gums, the roof of your mouth, your tongue, and the inside of your cheeks. You might have sensitivity in your mouth to spicy, citrus, or acidic foods, and you could develop mucoceles, which are blisters on the roof of your mouth. These occur, so they're filled with clear fluid, and they sort of will come and go. They'll pop up Maybe when you're eating or thinking about food, they can also occur on the inside of the lower lip. And they're filled with saliva. So when you have inflammation in your mouth, it squeezes the openings to your minor salivary glands shut. The saliva can't get out. So rather than, because it can't get out, it forms little blisters. These will eventually sort of recede and go back to the salivary glands, or they're able to leach out. It's better not to pick at these. They can become infected. Occasionally they can be painful, but generally they just sort of come and go, and they're just sort of off-putting when they occur. We know that oral graft-versus-host disease is really three distinct conditions, so oral mucosal disease, salivary dysfunction, and limited mouth opening. These can occur in the same individual, but when we look at our cases that we've seen at the NIH, they all three occur in less than 1% of patients. So although all of these manifestations are part of graft-versus-host disease in the mouth, they typically don't all occur at the same time. So it's important to remember that different clinical situations may need different treatment. If we see white lacy changes on the inside of your mouth and there's no suspicion that it could be caused by something else like infection or medications, then we can easily diagnose oral graft-versus-host disease in the clinic. We may need to biopsy the inside of your cheek to confidently diagnose graft-versus-host disease if there are other factors that could be causing those lesions. And if we want to diagnose salivary gland graft-versus-host disease, a small biopsy of the inside of your lip is really the only way that we can confidently do that. Important questions that they should be asking you in the clinic include, is your mouth suddenly drier? Is your mouth progressively drier? And this is as you're thinking about whether or not your salivary glands are affected by the graft-versus-host disease. Can you chew and swallow food without also drinking water? Are you taking any medications that can cause dry mouth? And did you have any irradiation, either total body irradiation or that targeted to the head and neck as part of your cancer therapy or transplant preparation? So like all chronic graft-versus-host disease, there's a difference in scale. The mouth might be the only site that's affected, and it could be quite mild. If you have bothersome symptoms or if your mouth is dry, you will likely need medication and supportive care. So once you have oral graft-versus-host disease, what next? It may be difficult to eat and possibly talk if the soft tissues of your mouth or other oral mucosa are affected. It's critical that you try to find something nutritious that you can eat. So soft foods like yogurt, mashed potatoes, overcooked carrots, smoothies, anything that's blended. I recently had a patient tell me that the only thing she was able to eat comfortably was the meat that came out of TV dinners because it's so soft. Popsicles or other frozen smoothies, yogurt, protein drinks like Ensure, peanut butter or other nut butters that are high in protein, and soft breads like Wonder Bread, for example. So these really like not structured white breads. So drinking room temperature water while eating and trying to stay hydrated can also help. It never hurts to ask a nutritionist at your cancer center for help in putting together the foods that you're able to eat as a nutritious diet. So numbing your mouth before eating can help you get in some calories. If eating is very painful, you can use viscous lidocaine or magic mouthwash, which is also called Litobenelux. Both are prescriptions for 30 seconds before eating. Swish, then spit them out and eat. Your food's not going to taste great, but you will be able to get it down. This is a short-acting anesthetic. This can also be used before any other oral rinses, medicated oral rinses that you might be using for your graft-versus-host disease that might be painful, so burn or hurt while your mouth is very raw. We typically will start treating oral graft-versus-host disease with dexamethasone rinse. This can be compounded at higher strengths. Those of you in Canada can actually get it really easily at higher strengths because it's on formulary at the pharmacies there. So this is typically held in the mouth for at least 2 minutes and then spit out. Longer contact times let the drug soak into your soft tissue. So if you are using medicated rinses, generally the idea is to hold them in your mouth. You don't have to actively swish. Just let them stay in there and then spit them out at the end of the prescribed time. And then after dexamethasone, we tend to move on to progressively stronger steroid rinses. Things like clobetasol can be used with the tissues. If you have isolated lesions, we often recommend applying a gel, either a steroid gel or if it's on the external lips, a non-steroid gel, something like tacrolimus. And if topical treatments aren't effective and oral GVHD is severe, then systemic therapy may need to be increased, changed, or added. So steroid pulses, ECP, and some other drugs have shown a positive major impact on oral graft versus host disease. And these obviously would be managed by your medical team. So mouth opening problems are usually related to severe skin GVHD and tend to get worse as fibrosis around the mouth progresses. You can counteract this to some degree by doing daily stretching exercises for the mouth and applying topical steroids or other creams around the mouth. If the mouth opening is very affected, it may require surgery to open up the tissues. So salivary gland graft versus host disease is silent. It's not as clear what causes dry mouth after transplant, drugs, graft versus host disease, dehydration, et cetera, and sometimes it's not recognized until the salivary glands are almost completely fibrotic. And at that point, they've lost their structure and their ability to produce saliva. So what can you do? If your mouth is dry, take frequent sips of water or a non-sugar drink. Cavities can progress really quickly in a dry mouth, and it's important to wash away any food or sugar that might be left in the mouth after you eat. Use a prescription fluoride toothpaste nightly. This is inexpensive. You can get it from your dentist, and it's helpful to remineralize the teeth. You can try stimulating your salivary glands using a sugar-free gum that contains xylitol. So I'm going to spell this. It's Xylitol. This is an alcohol-based sugar, so it's present in a lot of sugar-free gums. And it's helpful because it's also anti-karyogenic, so it helps to prevent cavities because the bacteria that live in your mouth really don't like this particular sugar. So there are also prescription medicines that can stimulate your saliva flow. These may take up to a month to work and may have side effects, so they're not for everybody, but they can be quite helpful. And then I will finish up by mentioning that there are a lot of dry mouth products on the market. They seem to really vary by individual taste, so you may need to try a few before you find one that helps. Really, these are typically just lubricating agents for your mouth that help keep you more comfortable and keep your tissues from sticking together. It's helpful if you can ask your dentist for samples of different kinds so that you can try them out before you spend money on them. And with that, I'm going to hand it back over to Jennifer.
Wow. Thank you. That was an abundance of great information, and I am so thankful for you taking the time to share that with us today. And just as a reminder to those who maybe haven't been on these calls before, I do send out notes within about a week of the things that the doctor and both our survivors say. So I will be making sure if anyone was writing super fast, I'll be sending notes as well to you. But again, thank you, Dr. Mays. That was amazing. Now I would like to introduce everyone to our next speaker, Cathy Spence. Cathy lives about an hour north of Toronto with her husband and two teen boys, aged 15 and 16. She was diagnosed with high-grade MDS requiring a bone marrow transplant in early September 2015. She was then diagnosed with AML in November 2015. There were insufficient BMT beds in Toronto, so she had a matched unrelated allogeneic peripheral stem cell transplant at Roswell Park Cancer Center in Buffalo, New York on February 24, 2016. This took a great deal of work and advocacy to accomplish, and as a result, she is an advocate for others going through BMT. Cathy is a peer mentor for us at nbmtLINK, and she's also a patient family caregiver advisory committee member for the CTTC, a large group of Canadian BMT and cancer experts that advocate for quality care and support of BMT patients. Despite a good match since the fall of 2016, Cathy has had fairly significant GVHD of her liver, lungs, skin, subcutaneous tissues, eyes, and mouth. She was fortunate to learn of the NIH's natural history study of GVHD and was even more fortunate to have met Dr. Jacqueline Mays, at the NIH. She has been very helpful in addressing her oral GVHD. Thank you so much, Cathy, for being here with us today.
Oh, well, I'm very delighted to be here. Thanks very much for the introduction, Jennifer. And as you said, I do live in Canada and just north of Toronto. I had my transplant in Buffalo, New York, because although we have universal health care here in Canada, that is health care for everyone, we do have limitations to access to some of that care. And there was a very long waiting list for a transplant bed. And thanks to the advocacy of some other patients, they were able to convince the government to sponsor us to go to the States to have our treatments if we could not get timely access to transplant bed in Canada. So I did have my transplant in Buffalo, New York, had fabulous care there, but then returned to Canada, and since then have had my follow-up in Toronto and at a cancer hospital in Hamilton, Ontario. So in Canada, we have universal health care. We do pay high taxes for it, but it's great not to have point-of-care charges and all the paperwork that you folks in the States have, and my heart goes out to you folks for all those problems you have. However, our universal health care does not cover dental care, and only for those who are on government subsidies does it cover medication. So for most people, it doesn't cover medication or dental care. I'm very, very fortunate to have had dental care and my medications, most of my medications, covered by a work drug plan. So some of the things that I say here, my experiences may be a little bit different from those of you in the States, and my ability to access some care and some medications not kind of a bit different as well. So if you can bear with me about maybe the differences in some of these experiences, hopefully there'll be a general understanding that that we generally are all in that similar boat with regards to our transplant and GVHD effects. So I had my transplant in February of 2016, but that was diagnosed in September of 2015. And prior to my transplant, I was really surprised to learn that I had to go to see the dentist before undergoing the transplant. I had no idea what the connection between my teeth and the transplant would be. Like, this seemed crazy to me, but I soon learned that there certainly is a big connection. So when I saw the dentist, I was fortunate to see the oncological dentist at the local cancer center here in Toronto. They did a very thorough examination. They were especially looking for any cavities, loose teeth, cracks in my teeth, looking at my wisdom teeth, and the general state of my dentition and oral hygiene. And as Dr. May said, they're looking at all this to ensure that there are no pockets of infection, sites for potential abscesses, that kind of thing, that when we are neutropenic, when we have very low white counts during our transplant, could then turn into serious infections. So they were pre-checking me, and I was really shocked to learn that they wanted to take out my wisdom teeth. When I was young, I kind of wanted them out because my teeth weren't exactly completely straight, and I thought that would be neat. But as I got older, there was no way I wanted my wisdom teeth out. And when they said they wanted them out, they said that there was no problem with them at that point, but that wisdom teeth are really hard to clean. And because they're so far back in our jaw, hard to get a toothbrush back there, hard to get toothpaste onto them. And so they wanted them out to be preventative, to be prophylactically aware that there could be a problem with abscesses and infection in the teeth. Well, I've just been diagnosed with cancer and having the transplant coming up, and some of the things going on in my life that I actually declined to have them taken out. I will admit my dentist, it was not Dr. Nose at the time, she was wonderful, and she did respect my opinion to not have them out. And to be honest with you, so far so good. I'm glad I didn't have them out. During transplant, obviously dental care and oral care was very important. When my platelets were low, I had to brush with this very soft foam-type lollipop toothbrush that Dr. Mays had mentioned in order to prevent any bleeding. As well, during transplant, I was asked to switch and spit with different medications, or like baking soda and some other cleansers to help prevent infections in the mouth and to decrease the inflammation of the tissues. But despite doing that fairly rigidly, doing the switching and spinning with these things, I did develop what Dr. Mays did talk about as well, was something called mucositis, which is basically an inflammation of the inside tissues of your mouth, not GVHD, but just, I think, related to chemotherapy and that kind of thing. And it really, I will tell you, it was very painful. Not everybody gets it, and I think it's quite rare. But unfortunately, I did get it, and it was probably one of my lowest points during transplant. I was off food for a week or 10 days. They fed me through my intravenous, and I had to suck. You get a lot of food, you get a lot of gunk in your mouth. You have to suck it out, and it is quite painful, but the transplant team were amazing. They managed my pain. They supported me, encouraged me, and I did recover, and after about 10 days or so. But if it happens, it's bearable. You'll get through it. Don't worry. After transplant, again, I was advised to take really good care of my teeth, see my dentist regularly. I do try and brush my teeth twice a day at least. I do use a fluoride toothpaste. I was fit with one of those plastic fluoride dental trays that Dr. Mays talked about, but mine did not fit well, and a few times they tried to change them around and chisel out my teeth to try and make the sense that, but they just never did. So I do use a oral fluoride switch and spit, high dose switch and spit fluoride liquid twice a day to try and increase, I guess, the mineralization of my teeth. But unfortunately, the oral GVHD did start to take a hold of me about 6 months after transplant. Because of the GVHD, I had very little saliva because the donor cells were attacking my salivary glands, and so obviously a very, very dry mouth. And you needed to take sips of water all the time. In order to eat, I still do need to take a sip of water with anything I eat. I have to chew it very, very well. I do avoid citrus and spicy foods, tomatoes, that kind of thing as much as I can. And again, I take sips of water all the time. If I can, I sometimes will brush my teeth after I eat. And I tell you, the toothpicks and the little gentle prodding things tend to be my best friend these days, because another side effect of transplant is that your gums can tend to recede. My gums have receded very, very much, unfortunately, so I have lots of gaps between my teeth, so the food gets stuck in there a whole lot. It's not very comfortable, so that's where the toothpicks come in handy. As well, with the gum recession, they have recommended, possibly if I want to have a gum graft, that's where they take tissue from the roof of your mouth, or they use cadaver tissue, and basically sew it onto the areas where your gums are receding the most, to try and help bump up that gum and prevent you from losing your teeth. These gum grafts have been done for many, many, many years, but not so much recently on GVHD patients. In fact, if I'd had it done, the gum dentist, it would have been his first gum graft on a GVHD patient. And I decided against it. I just thought my GVHD was pretty out of control at the point, and I just didn't want to risk chances of poor healing and that kind of thing, and to trigger it. So, again, I just decided to get something they suggested, but I'll still keep it in my back pocket. So my GVHD has been fairly constant with ulcers and fissures coming back and forth. I do have fibrotic tissue that is on the sides of my cheeks that prevent my mouth opening very full First time I noticed it, I went to go eat a banana, and oops, I couldn't open my mouth big enough to eat this stupid banana. But, oh my goodness. I do the gum stretch as a stretch as Dr. May suggested, and sometimes it's bad, sometimes it's not so bad. It comes and goes. I do have a very unusual coating in my mouth that's been there, although it's been 4 years since my last chemo. I do get a very unusual coating in my mouth almost constantly. Sometimes it gets worse. Sometimes it's even triggered by having a sip of water. I've said, boo, I got this coating in my mouth again. And I also do have a lot of taste aberrations. Used to love chocolate, don't like chocolate anymore. Certain textures feel very uncomfortable. But I just have to try different things. I've recently discovered, although like ice cream, which I used to love, doesn't work. Fudgicles, chocolate fudgicles too, and they just feel so good at my ulcers in the back of my throat. When I do have bad ulcers or fissures, I do use a dexamethasone switch and spit. One time I did have an ulcer that didn't heal for a long, long time, and they did finally swab it and did find it was a cold sore virus, a herpes simplex virus. And so I switched from my regular antiviral to another high dose valcyclovir, and the ulcer did finally recede. I've also been offered the pilocarpine and cevilamine, which are two medications that are very much related to each other, and they're supposed to help improve saliva. But as Dr. Marie said, that these do tend to have a lot of side effects, and I'm on so many medications that I just thought, I think I can handle it without adding on another medication. So again, I refuse care that they offer, so I think I'm really a difficult patient. Anyway, always feel free to make sure that you make your choice about how you want to manage your condition. So while I was dealing with your GVHD, I did develop other GVHD, as Jennifer mentioned, my liver, lung, skin, gynecologist, cold GVHD, the whole gamut. So at the time I was put on high-dose prednisone about 2 years ago. It's been tapered. I'm now on about 10 milligrams for about the past year. So that was hopefully going to help with my mouth. I don't really think it did that much. I also, to deal with these other issues, have been put on mycophenolate, sort of MMS, CellCept, you guys might know it as. Didn't really do much, and I got pneumonia while I was on it, so they stopped that. I've been on ibrutinib. I was on ibrutinib for about 9 months. Didn't really help my oral GVHD or my other symptoms, and I had pneumonia, so I was taken off of that. I've just recently been started on sirolimus and also on Jacqueline. I have great hope for these. These seem to be helping my breathing a bit, my skin a bit, but not so much my mouth. About 1.5 years ago, I started ECP, which is called extracorporeal photoplasmapheresis. It's a medical treatment done at the hospital, about twice a week initially, and then every other week after that. Blood is drawn out of one arm, mixed with a medication called Sorolin, and it gets exposed to ultraviolet light and then returned to the body through the other arm. And basically, it's a treatment that's supposed to help to basically just decrease the excitability of the white cells that we have that are attacking our cells. It was initially hard to tell if the ECP was helping or not. I wasn't really getting any worse, so I thought, well, maybe it's helped keeping things at bay. So I did continue it. I've been doing it for about 1.5 years. But with COVID, I stopped going down to have the treatments, and about 3 weeks after stopping them, my mouth exploded with ulcers and fibrosis. So I guess I found out that my ECP actually did work on my oral GVHD, and I certainly can't wait to start again. The other things that I've used to try and help with my mouth is obviously to try and pay attention to my oral hygiene, brush my teeth, check my gums, that kind of thing. Use the fluoride toothpaste. There's something called Colgate has a Prevident, which has high fluoride. It comes in a spearmint and berry flavors, but as Dr. Mays alluded to, I am very sensitive to mint these days. I cannot handle it at all. So I was very happy that this toothpaste offered it in a berry flavor. I've also used all the Biotine and Act and Colgate product mouthwashes for dry mouth, but honestly, they didn't really help me very much. I've tried the different sprays, the Biotine spray, but the relief only lasted like 5 minutes or so I didn't really use them very often anymore now at all. I also found that the xylitol sprays and the dry mouth candies with xylitol unfortunately didn't help me. I'm sure they were very helpful for other people. but just not for me. There's something called Xylomelts, which has xylitol in them as well. They're small lozenges that actually stick to your gum line, and they discharge some relief as they melt. They're a little bit minty, so I'm not super keen on them, but I do use them from time to time. They're also recommended to use overnight, so that you attach it to your mucosa of the gums and sleep with them. But honestly, I've been a little afraid of aspirating them in my lungs, and so I haven't used them. But I've spoken to a lot of people who actually do use them overnight, and they've never had a problem with that. So I think probably to try and get some saliva going and relief overnight, they're probably a good option. There's gels available. I haven't really found them to be helpful either. I did use an orange-flavored xylitol chewing gum initially, but once you were done with the gum, you were done with the relief, I found. So unfortunately, there's a lot of care products out there, but I really haven't found anything that's been universally helpful, unfortunately. As I said before, sometimes I just try and treat it symptomatically by avoiding the foods that are uncomfortable for me. Take lots of sips of water with the food. Warm drinks are often comfortable in my throat, or sometimes cold drinks or cold food to basically numb the discomfort. I sometimes use a straw if my ulcers are very painful. But essentially, the oral GVHD certainly has been a challenge. But thanks to the wonderful care that I've had from providers such as Dr. Mays, they've been able to help me with my oral concerns, have given me support and suggestions for relief, and lots of really nice soft toothbrushes. So they've been great. It's a journey, and it's tough, but it's well worth the fight. And if there's any way I can offer any support to you folks, please don't hesitate to ask any questions. Okay, thanks very much, Jennifer, and I'll hand it back to you.
Thank you so much, Cathy. I really appreciate your authenticity, and you are just a wealth of information as well. I have a question for you that I'd like to ask before I move on to our next section. If you had to summarize a few things that helped you to deal with the emotion of dealing with, or even the mental difficulty of dealing with chronic graft-versus-host disease, what would you say are a few of the tools that have helped you cope with dealing with chronic graft-versus-host?
Sure. The GVHD has been very difficult to deal with, and I'll be honest with you. It was a shock. Before I went for my transplant, because initially I was going to Canada and then I was going to the States, I had 2 big counseling sessions with the main doctors, and with both physicians in the States and in Canada, they really minimized GVHD. And so when I did end up having it, it was a bit of a shock. Personally, I would have liked to have known more about it before the transplant. Would not have changed my mind as to whether to have it or not, but it would have given me a sense that it could happen, and when it did happen, I wouldn't have been as shocked and disappointed. How I've been coping is that for most of the GVHD, it's not going to kill you. My lung, to be honest, my lung GVHD is a stairs. Okay? It probably is one that could, but the other ones are really uncomfortable and they're risky, and the medications like prednisone that you have to use to survive them have such terrible side effects, whether that's necrosis or the hips and knees, whatever, and people having lots of joint replacements. But what's helped me cope is that thinking, well, I'm alive. And for myself, I've had 4 years since transplant. I've gotten to see my boys grow. I've had all sorts of wonderful experiences. So I'm just so thankful that I'm alive. I'm a little bit peeved because I have other friends who've had cancer once they have their treatment, and although they have fear of recurrence, they don't really have this ongoing major medical problems. But I have survived. I look at all the silver linings. There are many, many silver linings, and I know we've talked about that in some of our previous lunch and learns, so I concentrate on the silver linings, on the new appreciation for life, for family, for love, for all the good things that we have going on in our life. I also do belong to a Facebook group on GVHD and on bronchiolitis obliterans, which is the GVHD in my lungs, and have found that to be very helpful in that you realize you're not alone. I take support from groups such as yours, Jennifer, that help support us all and help us realize that we're in this together.
Great tips. As always, we appreciate you so much. Okay, now before we had our program today, some of you had submitted some questions, so I'm going to hand things over to Dr. Mays for a moment to answer some of those. And then I know we're going a little long today, but we will add a few minutes to this if you're able to stay and join us for additional questions. But Dr. Mays, could you answer some of those previously submitted questions?
Of course. Thanks so much, Jennifer. So some of you had sent in questions about paying for dental care. This is a major challenge. I will be quite upfront and tell you that I work at a free clinic, and working the social safety net and insurance coverage are not my strong suit at all. So resources to help pay for dental care vary a lot by region. So a local social worker at your cancer center could hopefully help you to find local resources. A state dental society may have a list of resources that are available, and oftentimes, as I mentioned before, a local dental school, and there are typically one or two in most states, will have a resident clinic. These are licensed dentists who are there for additional training, and those clinics will have reduced fees and will be able to do most of the treatments that you need. Okay, so that was question number 1, and probably 2 and 3 also of the ones that have come in. So there were a couple of questions about bone loss after transplant, so bone loss specifically around your teeth. So someone had asked how common is progressive periodontal disease and eventual tooth loss post-transplant. Is it from graft versus host disease or the extreme chemotherapy or both? So I will tell you that based on what I've seen, because there really are no good studies out there in the literature, bone loss can come from long-term steroid use. And we know that a lot of times patients are on years and years of prednisone use after transplant, but we're not sure if it's directly related to graft versus host disease. It is a common problem, so both periodontal disease and bone loss in graft versus host disease patients, and it seems to be more prevalent than in the general population, so people that are of a similar age. I suspect that it can also be related to total body irradiation or focus radiation as well. So we don't have great answers. I suspect it's more related to chronic steroid use than it is actually to graft versus host disease. Somebody else asked right now, I'm about 10 years out from transplant and have extreme sensitivity to both hot and cold. So I assume that this is like hot and cold with your teeth. So this is most likely a dental or a tooth problem. I would recommend starting with a desensitizing toothpaste and possibly some fluoride varnish treatments at your dentist's office. So this is the kind of fluoride that they paint onto your teeth. Both of these things can help with sensitivity. A dental exam might find some small cavities or maybe some exposed tooth roots that are making you more vulnerable to tooth sensitivity. 2 people asked how to best care for your mouth and gums when the doctor says you can't go to the dentist yet. So brush and use mouth rinse. If you are 6 months out from transplant and are doing well, you should really revisit the topic of going to the dentist with your medical team. So they might have said when you left the hospital that you couldn't go to the dentist, and they may not have thought about it since then. So check back with them if you're past that 6-month mark, and they're recommending that you shouldn't go. What to do if you have a toothache when you're not supposed to go to the dentist. So it's much more dangerous to have a dental infection and to have sort of an abscessed tooth than to have dental work done early after transplant. So that said, if you have access to a hospital-based dental clinic, this is the best place to get treatment when you're in the early months after transplant. Just a couple more from the pre-submitted questions. So Revlimid or lenalidomide, there was a question about whether this can contribute to bone loss. So lenalidomide, which is Revlimid, pomalidomide, and other thalidomide-derived drugs have not been related to bone loss or other dental issues. We've actually, in a clinical trial at the NIH, seen some modest improvement in oral graft versus host disease with patients on pomalidomide, but we really didn't have enough patients with serious graft versus host disease in the mouth to make a good determination on that in that particular trial. 2 more questions. Someone asked how to get rid of ongoing tongue ulcers. So these can be really bothersome and quite persistent for a long time. If I see these in my clinic on patients with chronic graft versus host disease, I tend to treat them by using a tiny needle to inject a steroid called triamcinolone around the ulcer base. So this is the same steroid that's injected into the joints for arthritis patients. It's a little bit like throwing a hammer at the ulcer to convince it to close. So we'll repeat this every 2 weeks, if possible, until the ulcers close up. So because of the sides of the tongue are often a site for oral cancers to develop, we try to reduce the inflammation and close ulcers at those sites in particular. So it's not the most comfortable treatment, but it is a good way to get those ulcers to close up. And this is treatment that can be done through an oral medicine specialist, through an oral surgeon, or even a periodontist could do this for you. Finally, the last question is that I have GVHD of my lower lip. It's raw and bleeds. I tried a number of creams prescribed by my dermatologist and oncologist to no avail. So I will just mention that this may need to be biopsied if it's been raw and bleeding for a long time to make sure it's not dysplastic tissue or tissue that's growing abnormally. It may help if you protect the area as much as possible, so coating it with petroleum jelly, reducing sun exposure, and protecting it from abrasion from any food or toothbrushing could help it to heal a little bit more. Normally in our clinic, steroid creams or gels or tacrolimus gel would be my go-to for treatment. And there's some evidence that low-level laser therapy, cold lasers, or photobiomodulation, it's all different words for the same kind of treatment, have been used successfully for similar isolated graft versus host disease sites. And that's a treatment that's not available everywhere, but there are some centers like UPMC in Pittsburgh that do offer this treatment. And that is the last of the pre-submitted questions that I had on my list. So I'll hand it back over to you, Jennifer.
Thank you so much, Dr. Mays. Okay, Hannah, can you please share with our callers how they can ask their own questions today?
Yes, thank you. If you would like to ask a question, please signal by pressing star followed by the 1 on your telephone keypad. Also, if you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. You may state your name before posing your question. Once again, that is star 1. And again, that is star 1. We do have a question in queue. We'll go to our first question.
Yes, I have one response first, and it's regarding helping others. I do use a tooth and gum tonic that is made in New Hampshire. It's all natural, and that has been extremely successful for me for any mouth issues that I've had, and covering a lot of the things that the doctor spoke about with sores and what have you. My question is extreme sensitivity. I did learn from your conversation today about the Xylitol, and I do take fluoride treatments at least twice a year, and I do use a fluoride gum. Fluoride paste, I'm sorry. I was looking to see if there's anything else with sensitivity you can do in the interim, if there's anything more, whether like maybe baking soda solutions or something more natural. That's pretty much it.
Of course. So there are desensitizing treatments that your dentist can put on your teeth. So there's something called Gluma that they can paint the teeth with, and then that tends to be effective for a few months at a time.
Okay.
It's great to hear that you're using fluoride toothpaste, so that's super. And I'm glad that you found something that really helps your mouth. Oftentimes this is an individual preference, so it sometimes takes a little bit of looking to find something that's working well for you. As far as natural products that will help your sensitivity, I don't really know of much. Unfortunately, I wish I had something that I could recommend for you.
Okay. It's tough because I also have to wear a mouth guard because I am a grinder, and I think that actually promotes some of the sensitivity on top of the graft versus host.
Yes, for sure. It absolutely does, that grinding. You know, if you're wearing a mouth guard for grinding at nighttime, depending on the type of mouth guard it is it the type that sits on your top teeth?
Yes.
So you may be able to actually put a little bit of fluoride gel in that mouth guard before you put it on at nighttime, and that could help with some of your sensitivity. It's not going to take it away completely, but it could help it.
Fluoride, is that what you said?
Yeah, so your dentist can prescribe fluoride gel for you, and you can put just a very thin amount of it in that mouth guard before you put it on.
Okay. Thank you so much.
Good luck.
I wish I would have known you like 10 years ago when I was just post-transplant.
I bet many people feel the same way.
Yeah. Thank you.
Thank you.
And once again, if you'd like to ask a question, that is star one. Looks like we have no further questions in queue.
Okay. You know, I have one question really quickly, Dr. Mays. I know sometimes when I had worked in oncology for many years at the hospital, and sometimes we had involved hyperbaric treatments. Is that ever used with anything with chronic graft versus host disease, or is that mainly just for necrosis? Or
Well, that's a super interesting question. I've seen some studies where they've used hyperbaric oxygen chambers to treat bone infections, like in the jawbones. But I'm not aware of anyone who's used it successfully to treat graft versus host disease.
Okay. All right. Well, thank you. But I want to thank both of our speakers today. I'm sure that I echo many people on this call that this was incredibly informing. And I also, of course, want to thank everyone for joining us today. I just want to give everyone a heads up that you can stay tuned for our next Lunch and Learn next month, June 17th. We're going to be having Dr. Harry Erba, who will be speaking to us about AML. And then if you would like any further information about survivorship issues, if you need more support or you have some questions or you want to talk to a peer or you want to be a peer, please feel free to reach out to us at 1-800-LINK-BMT. Again, thank you to our speakers, our sponsors, our link partners, and all for joining us today. Have a great day.